All right, let's dive into a topic that's absolutely crucial for every single surgeon: surgical site infections. We're going to tackle this using the safe surgeon paradigm, which is all about understanding not just what to do, but really why we're doing it.
This isn't just about dodging a complication. It's about seeing a huge opportunity to really step up and protect our patients. So let's get into it. First things first, let's talk about just how big this problem is. Surgical site infections, or SSIs, make up a whopping 20% of all hospital-acquired infections. That's huge. It makes them the most common and, you guessed it, one of the most expensive headaches in all of healthcare.
And this is exactly where that safe surgeon idea comes in. See, modern surgical exams and practice aren't about just memorizing a bunch of facts. It's about developing that gut instinct, that sharp clinical judgment to spot trouble early and use evidence-based protocols to stop infections before they even have a chance to start.
Okay, let's put this to the test. Imagine this. A patient 6 days after a colectomy suddenly spikes a fever and you see pus coming from the wound. What's your move? Well, the safe surgeon doesn't just throw more antibiotics at it and hope for the best. Nope. The right move is all about early recognition and source control, getting to the root of the problem. And that's exactly why B is the right answer.
So to make that right call, you've got to understand the situation, right? You got to classify the battlefield. And that means answering two really important questions. How deep is the infection? And just how contaminated was the surgery to begin with?
Let's start right at the surface. A superficial incisional SSI, as the name implies, only involves the skin and the fatty tissue right underneath. The key things to remember here are the 30-day window and how you diagnose it. Either you see obvious pus, or the surgeon has to physically open the wound because it just looks infected.
Okay, going one layer deeper, we've got the deep incisional SSI. Now we're talking about the fascia and muscle. And here's a super important point. The time frame actually extends out to 90 days if there's an implant, like a mesh. You nail the diagnosis by finding pus deep in the wound, seeing the wound separate while the patient has a fever, or spotting an abscess on a scan.
And then we get to the most serious one, the organ/space SSI. This is an infection way down in the actual body cavity or organ we operated on. And again, notice that 90-day window if there's an implant. The diagnosis here is pretty clear-cut. You either see pus coming out of a drain placed in that space, or an imaging scan shows an abscess.
Now here's a really high-yield detail, especially for exams and reporting. The purulence rule. It's simple. If you just write down the word pus, that's good enough. But if for some reason you don't use that word, you have to describe both the color, like green or yellow, and the consistency, like thick or creamy. And this is a big one. Just seeing white blood cells on a lab slide is not enough to call it purulence.
So that's the how deep part. The other half of classifying the situation is the wound class, which basically predicts the risk of infection. A totally clean case like a thyroidectomy has a really low risk. But on the other end of the spectrum, a case with perforated diverticulitis is considered dirty, and the risk of an SSI shoots way, way up.
Let's see how this works in real time. An elective gallbladder removal? That starts out as a class 2, a clean contaminated case. But what if that gallbladder pops and spills infected bile everywhere? Well, the game has changed. You have to immediately reclassify it as a class 3, contaminated. This kind of dynamic on-the-fly reclassification is a core skill for a safe surgeon.
Okay, so now we know how to classify infections. Let's shift gears and talk about prevention. And believe it or not, this whole process starts weeks, sometimes even months, before the surgery, by getting the patient's own defenses ready for the fight.
These are the heavy hitters. We've got to get blood sugar under control. We have to tackle malnutrition. We absolutely need patients to stop smoking at least 30 days before their operation. For those high-risk implant cases, we decolonize the skin and nose to get rid of resident bacteria. And one last simple but critical point. We clip hair right before surgery. We never ever shave it.
Let's zoom in on glycemic control for a second. An HbA1c, think of that like a quarterly report. It gives you the big picture 3-month average. But what if the surgery is in 3 weeks? You need something more current. That's where fructosamine is a game changer. It shows you their glucose control over just the last 2 to 3 weeks, which makes it perfect for tracking those short-term optimization efforts.
All right, now we're heading into the operating room itself, the sterile fortress. This is where following strict protocols and making sharp decisions under pressure is everything.
And here it is, a classic board exam trap.
You've got a patient with a mesh repair and a couple of drains still in place. It's been 48 hours since surgery. So what do you do with those prophylactic antibiotics? Everything in your gut might be telling you to keep them going because of the mesh and drains, but that's the trap.
The answer is C. They should have been stopped a day ago. This is the 24-hour stop rule, and it is absolute. You have to stop prophylactic antibiotics within 24 hours of the surgery ending. It doesn't matter if there are drains, implants, anything. Keeping them going longer doesn't lower the SSI risk. It actually just increases the risk for other nasty stuff like antibiotic resistance and C. diff.
Here's another incredibly powerful strategy you can use right in the OR, the clean closure. After you've finished the dirty part of an abdominal case, the entire team, everyone changes into fresh gloves. Then you use a completely new, separate, sterile set of instruments just for closing the wound. It's so simple, it's backed by evidence, and it really works to bring down infection rates.
Okay, on to the final phase, post-op care. I like to call this vigilant rescue. It's all about being hyper-aware, recognizing those subtle signs that something's wrong, and jumping in early, especially with something as serious as an anastomotic leak.
This table is a fantastic roadmap for managing those leaks. For a mild, grade A leak, you might just watch and wait. A grade B, with a nice contained abscess, probably just needs a drain placed by radiology. But a grade C leak, with full-blown peritonitis and sepsis, that's a surgical emergency. That patient is heading straight back to the operating room, no questions asked.
So let's run through one last post-op scenario. It's day 1 after surgery. You see a little bit of redness around the incision, but the patient feels fine, vitals are normal. What do you do? The key here is all about timing. SSIs don't usually show up this early. They tend to pop up around day 5 to 10. That early redness? It's probably just normal inflammation. So the safe surgeon approach is to simply mark the borders with a pen and monitor them closely.
So, after all of this, what does it all boil down to? What is the core takeaway? What's the code that every safe surgeon should live by?
It's really this simple. The best complication is the one that never happens. True mastery over SSIs isn't about being a hero and picking the perfect antibiotic after your patient is already sick. It's about meticulously managing every single step of the journey before, during, and after surgery to create an environment where an infection just doesn't stand a chance.
Hey, if you found this guide to thinking like a safe surgeon helpful, make sure you like and subscribe to ABSITE Daily Dose. We've got a lot more high-yield content coming to help you sharpen your skills. Thanks for watching.